Yes, yes.
That's good.
So maybe you can make me also what you call it, host. Better if in case, because the presentation is with me also.
Okay, so but Dr. Abdullah Firdaus is gonna present first.
Yes, yes, he will. He will. In case I don't know where is he now.
Okay, sure. So I will mute you. Dr. Abdullah.
السلام عليكم دكتور أحمد، كيف حالك؟
وعليكم السلام، يعطيك العافية. Thank you for joining us.
الله يعافيكم.
I just want to make sure that you will able to share your screen. Can you do that?
I will give me just 30 seconds.
Excellent. I can see your screen very well.
All right.
Research ka dahil?
طيب, I guess we should start. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. It's a pleasure to be moderating and hosting this monthly trauma surgical critical care chapter meeting. And what better way to start it this year, inshallah, rather than by presenting a very interesting case that was encountered by our colleagues in King Saud Medical City, a major trauma center in Riyadh that, mashallah, always seems to be getting the major cases and doing an excellent job of managing such severe trauma cases. Our speakers today are Dr. Sharafuddin Chaudhry, who is a trauma consultant and the director of trauma in King Saud Medical City, and he's a great colleague and a friend of ours. And Dr. Abdullah Al-Firdaus, who is a senior trauma fellow and a consultant general surgery from the southern region, who has also been involved in this case. I don't want to take longer in presenting these our two great speakers. I would like to give the mic to Dr. Abdullah Al-Firdaus to start his presentation, and hopefully a wonderful experience. Thank you everyone for coming.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على خاتم النبيين وبعد. First, I want to thank Dr. Sharafuddin. He is the treating consultant of our case report. As presented by Dr. Ahmed, Dr. Sharafuddin is a trauma surgeon and surgical intensivist, and he's the director of trauma center at King Saud Medical City in Riyadh. I want also to thank Dr. Ahmed Al-Boykan for his great effort in arranging this night meeting and for accepting being the moderator. Dr. Ahmed is a trauma surgery consultant and intensivist, and he's an assistant professor of surgery at King Saud University in Riyadh. I would also want to extend my thanks to the Surgical Critical Care chapter of the Saudi Critical Care Society for sponsoring this activity. The roadmap of our presentation tonight has 3 steps. First, we will pass by a short introduction and a detailed anatomy of the subclavian vasculature. Second, I will present our case that we have succeeded in managing, alhamdulillah. Third, I will present some papers review, and we might end up with discussion. The incidence of subclavian artery injury is very rare. In World War I, its incidence was 3.8% from the total arteries injured. In World War II, it was only 0.9%. And in the Korean conflict, there were 3 cases only, and that was equal to 1%. In the Vietnam War also, it was around 1%. Those injury is associated with a high mortality, and they remain extremely lethal injuries. The management is challenging due to the difficult anatomic location and the difficult exposure, and also due to the multiple numerous vessels and nerves structures in that area. The arch of aorta have three main branches. To the right, you can see here is the brachiocephalic artery or the innominate artery. It gives rise to the right carotid artery and the right subclavian. The other two branches are the left common carotid, and then posteriorly is and distal to the left side is the left subclavian artery. Here is a CT image. It is showing the three branches, and you can see clearly here how the left subclavian artery is located deep posteriorly. Medially and superficially here, we have three main muscles that we have encountered during managing those injuries. The most superficial is the sternocleidomastoid, and deep to it, there is sternohyoid and sternothyroid. Those muscles are covering the upper border of the proximal part of the left subclavian artery. And you can see here how the proximal part of the artery lies deep to the strap muscle medially. And in its second part there, the artery is lying deep to the scalenus anterior muscle. Then it will go lateral and inferiorly to pass in front of the over the first rib to continue as the axillary artery. Here are the portions of the subclavian artery. The first portion is the portion from the origin to the medial border of the scalenus anterior muscle. So you can see here the scalenus anterior muscle is originating from the C3 to C6 transverse pro6, and it's inserting in the first rib. So this is called the first part or the first portion. Second portion is lying deep to the scalenus anterior muscle, and the third portion from the lateral side of scalenus anterior muscle to the lateral side of the first rib. You can see here also how scalenus anterior muscle is an important landmark in this anatomy. It separates the subclavian vein from the artery. The vein is located anteriorly and inferiorly. The artery is superior and deep posteriorly. And the brachial plexus lies deep to the artery. Here is the brachial plexus lying posterior to the artery. And as we mentioned, the artery is passing in its second portion deep to the scalenus anterior muscle. So this is the scalenus anterior muscle, the artery, the brachial plexus. There are 5 branches of the subclavian artery. They are usually recalled as vitamin C and D. B, it's for vertebral artery upward, the first branch. I is the internal mammary artery, downward. T for the thyrocervical trunk, upward. C is for costocervical trunk. And you can see all those important branches are branching from the first part of the artery, especially in the left side. In the right side, the fourth branch, which is the costocervical trunk, is branching posterior to the scalenus anterior muscle, which is in the second part of the artery. Okay, one added point for the branches that they have only small free interval between one another. So it's almost 1 centimeter to 2.5 centimeter between the commencement of the artery and the origin of the nearest branch. The third branch, what we call the thyrocervical trunk, is the most important for collaterals. It gives two important branches, the transverse cervical and the suprascapular. Those two branches you can see here, they are anastomosing to the subscapular artery, and subscapular artery is like making a bypassing this area of the subclavian artery to enter to the axillary artery to supply it. Another collaterals are coming from the carotid artery. You can see here the external carotid artery, and the collateral is going from the external carotid to the thyrocervical trunk, or from the external carotid also to the costocervical trunk, and it's going to supply the subclavian artery, especially if ligation happened here very proximally or proximal to the vertebral artery. We have two major collaterals, and the main artery for collateral is the thyrocervical trunk. Lastly, we have two more nerves that we have to take care of. The vagus nerve, it's running medially, and it's just lateral to the carotid artery. And the other nerve is the phrenic nerve, which is crossing the scalenus anterior from lateral to medial. And those two important nerves should be identified and isolated. So from anterior to posterior, we have subclavian vein, then scalenus anterior muscle, then the subclavian artery, then the brachial plexus. Our case, he's a 21-year-old male. He was stabbed with a knife on the left side of lower neck in the supraclavicular area around 7 p.m. on in the last July, 14th of July. He presented to Al-Aflaj Hospital initially. At Al-Aflaj Hospital, he was stable hemodynamically. He was having active bleeding from the wound. They managed to resuscitate the patient there. They intubate him. They apply pressure dressing, and they insert a left intercostal tube. From there, they shifted him to OR. And the general surgeon there extended the supraclavicular wound, and he applied multiple different sizes of bulldog, as shown in the picture, to get temporary bleeding control of as what he described as pulsatile bleeding. Then the patient was shifted to King Saud Medical City Trauma Center as a life-saving case. At King Saud Medical City, he arrived at 2:30 a.m. on 15th of July. Trauma team was activated, and also vascular surgery team was called by the emergency department consultants. Airway, patient was intubated. For breathing, he was ventilated with FiO2 60% and saturation is 100%. Chest X-ray showed left hemothorax, and the ICT was draining 700 ml of blood. His pulse was 92, and his blood pressure was 109/63, and he was not on inotropes. For disability, he was sedated and his pupils were reactive. His VBG showed pH of 7.35, bicarbonate 21.7. The BCO2 was 36.1. The base deficit was minus 3.4. Lactate was 2.2 and hemoglobin was 7.6. Examination of the extremity showed that the left hand is cooler compared to the body and the right hand, but it was perfused. The pulse oximetry showing pulse with 98 and 99% of oxygenation. But there was no palpable pulse and no Doppler signal in the distal arterial sections in the left arm. The massive transfusion protocol activated and we alert the operation room. Based on his normal blood pressure and stability, we shifted him for CT scan brain, and we did brain and CTE neck and chest, and for also to assist the left upper limb. The CT brain was unremarkable. The CT angio showed complete cut off of left subclavian vessels after its origin. There was severe metallic beam hardening artifact causing the difficult evaluation of the second part of the left subclavian artery. There was hematoma surrounding the left axillary vein with the patent lumen. The left axillary artery and brachial artery appear patent. The left vertebral artery was originating from actually from the arch of the aorta, from the aorta down, which is a variant on 10% of patients. And there were left moderate to large hemothorax. Post CT scan patient was borderline despite blood transfusion and fluid resuscitation, and the ICT output increased to 1.2 liters. And from there, we shifted him to OR immediately. In OR, we started with the extension of the wound and make a left supraclavicular incision. And we divide the clavicular bone. We were unable to get proximal control of the artery, and patient will start to ooze. So we decided to proceed to immediate sternotomy. With the sternotomy, we open the left pleura and we evacuate 2 to 3 blood from the left chest cavity. He was unstable with inotropes on table, so blood transfusion was ongoing. He received 7 units of backed RBCs, 4 units of fresh frozen plasma, 4 units of platelets. So we decided to ligate the injured subclavian artery. We find subclavian artery is transected totally, so we end with ligation of the artery. Post operation, we shifted the patient to ICU. Post-op, he was gradually weaning from the inotropes. He was extubated on day 2. He was shifted to general ward on day 3. The intercostal tube was removed on day 9. We did follow up the CT angio. It showed post-surgical intervention findings of ligation of the proximal left subclavian artery. And there was refilling of the distal segment of subclavian artery, and its branches is noted down to the left forearm. So we discharged the patient on day 10 and advised to use left upper limb compressive stocking for swelling. At follow-up, he has normally perfused left upper limb. He was neurologically fully intact, and the swelling was almost resolved. For the third part of our talk today, the literature review and the discussions, we formulated 6 highlighted questions and tried to find answers in the literature. The first question is, was it better for the referring surgeon to use a balloon compressing instead of using bulldog's clamps bluntly? Considering that the patient will be sent to King Saud Medical City, which is 3 hours away. The second question was it better to refrain from the preoperative CT angiogram? The third question is, was it better to perform a high thoracotomy or trapdoor incision instead of median sternotomy? Fourth question was it better to perform a distal control by making another distal infraclavicular incision over the axillary artery in the deltopectoral groove? Fifth question was it better to manage him using an endovascular technique? And the last question is, was it better to attempt vessel grafting instead of ligation? For the first question, which is the balloon compressing
Dr.
feeder.
Abdullah?
تفضل دكتور أحمد.
Yes, I would like to thank you for this excellent presentation of the case. Actually, I had some questions in my mind, but I think the questions that you will be raising, the 6 questions, will answer most of our dilemmas perfectly fine. I just want to alert the audience before you start your literature review. Please, if you have any comments or any questions, just click on the raise hand button, and then we'll try to address all of this after Dr. Abdullah finishes his presentation. Thank you very much. كمل يا دكتور عبد الله يعطيك العافية.
Regarding the first question, we found a paper by Dimitriadis in 1999 for penetrating injuries to the subclavian and axillary vessels. It was a retrospective review, and it includes 79 patients. It mentioned that for retroclavicular injuries where direct pressure is often not possible, balloon tamponade with a Foley catheter may be effective and was successfully used in 4 patients. The paper here, there, then it's describe the technique in details. This paper also mentioned that application of balloon tamponade may allow safe transfer of the victim to a trauma center or from the emergency room to the operating room. Another paper to try to answer this question, it was by Subnak et al. It includes 50 patients managed at Cape Town, South Africa. The paper mentioned that Foley catheter balloon tamponade can be used in an attempt to control bleeding, especially from the retroclavicular region. The paper added this swab on a stick can be used to apply pressure to minimize bleeding during exposure. So maybe using blind applying vascular clamp is unsafe, although it was the way used to save the life of this patient that we have presented. The second question is, was it better to refrain from the preoperative angiogram? Subnak, again, in his study of the 50 patients, it was a retrospective study. the 50 patients, 40 of them were stab and 10 of them were due to gunshots. Here you can see to the left in the presentation, 48 of the patients presented acutely within the first 24 hours from injury. Then also down to that, 43 of them were stable with the systolic blood pressure above 90. Around half of the patients presented with a form of bleeding, like bleeding or large hematoma or pulsatile hematoma. And around the other half presented with pulse deficits. To the right here, you can see that the pre-operative angiogram was done in 37 patients out of 50. And it was only done in one patient with pulsatile hematoma and in only one patient with large hematoma. The angiographic finding was occlusion or transection in 13 patients out of the 37 patients. Another 13 were having pseudoaneurysm. So as per Subclavian, rarely pulsatile hematoma or large hematoma made them to scan their patient pre-operatively. But Subclavian, in his conclusion, he stated that pre-operative angiogram was useful in planning an operative approach. Primary repair was possible in the majority of patients, and ligation of subclavian artery injuries was life-saving in critically ill patients. Another paper by Lin et al. It includes 54 patients over a 10-year period. 18 patients from the 54 patients were unstable. That is around 33% of the patients, they were unstable or with pulsatile bleeding or with large hematoma, so they were taken directly to OR. 6% or 3 patients with no recordable blood pressure, they underwent resuscitative thoracotomy. The remaining stable patients, there are 33 patients with, or 61% of the patients, they underwent angiogram to identify the location of the injury. You can see here to the left that 46 patients were gunshot patients and 5 patients only with a stab. The stable patients, they were 61%. So this study by Lin et al. Didn't mention that whether the pre-operative angiogram affected the patient's outcome, but it mentioned that the presence of multiple injuries near the stable, like for example, the subclavian vein injuries were associated with the mortality. If three or more associated injury, the mortality reached to 83%. He mentioned some of those associated injuries. They were mostly subclavian vein in 44%, followed by brachial plexus in 31%, and some patients with associated intra-abdominal injury requiring exploratory laparotomy. Other factor for mortality was the gunshot injury compared to the stab wound injury. patient sustaining stab wound to the subclavian artery had an 80% survival rate, whereas those sustaining gunshots had 63% survival rate. Subnak and Lin, both of them advocated the use of pre-operative angiography in patients with no pulsatile bleeding and in patients with systolic blood pressure above 90. The third highlighted question is
Dr. Abdullah.
تفضل دكتور أحمد.
I think before we move on into your operative exposure, let us discuss some of the dilemmas that happened before. If you may allow me, I just want to pose a couple of questions for you and maybe for Dr. Sharaf. Hopefully, also to elaborate more on the first two questions, the three questions that you have tried to answer. First of all, the patient presented to Al-Aflaj hospital and he was transferred. And my questions about this issue that happened. Do you feel that the patient was properly resuscitated in Al-Aflaj hospital? And was there a physician accompanying the patient? Was there communication with you guys before the patient was transferred from there or during the transfer? Did you think the use of bulldogs by the doctor complicated the injury when you guys eventually dealt with it? And because you proposed maybe a Foley balloon instead, do you think that the Foley balloon would have controlled the bleeding during the transfer? You have seen the injury eventually. Do you think that if the surgeon there have put in a Foley balloon, would it have stopped the bleeding rather than the bulldog to make the patient transferable or no? And in retrospect, did you think that your CT angio was helpful for you? So maybe if you can answer us about regarding these questions from the light of your experience rather than the literature. What do you think is how would you answer such questions?
I will raise it to Dr. Sharafuddin, but
thank you very much.
Yes,
thank
Dr.
you,
Sharaf,
thank you very much, Dr. Abdullah. Your nice presentation, and actually you structured the presentation in a very nice way. You described the anatomy, and then you described the case report, and you actually then I feel more you are asking yourself, and which is very good. And then you did the literature review to get the answer of those questions. So first of all, if we start from the beginning, obviously Al-Aflaj Hospital is a peripheral hospital. I don't think they have many experience with such vascular cases. This is number one. And mainly, the hospital is served by the general surgeon. Even in a busy trauma center, we don't see so many cases with subclavian injury. Although you may see cases with neck trauma or penetrating neck trauma. So in that case, although I do not agree with them, like the way they dealt the patient, because patient it was stabbed with a knife. So the tip of the knife may be injured artery or most likely vein, because vein is slightly superficial than artery, or maybe both. But when they saw some bleeding, I'm sure they became more scared. And then they took him to war, then they extended the wound and they put some bulldogs or vascular clamps blindly. So that's why the extent of injury, I'm not quite sure when I received the patient in my hospital. But at the same time, I would like to congratulate them because they did a great job actually by doing this. Even if you don't know the anatomy or you don't know the because maybe they were not trained in a trauma center or something, but they saved his life and they did correct. They stopped the bleeding and they immediately transferred the patient to a level 1 or designated level 1 center. where the trauma surgeons are available. Although it was 300, almost more than 300 kilometers, it took 3-4 hours to come here. Despite that, retrospectively, I think the surgeon did a great job regarding stopping the bleeding. And the resuscitation, I would not say they did very bad, because when I received on presentation, if you look at his pH, his lactate, his base deficit, even his hemoglobin, even his ICT, he was in a stable condition. So I would rather again congratulate them. They did a good job in terms of resuscitation. They intubated the patient, they put a ICT, they did temporary hemorrhage control. Communication, I was not sure, because I was called by actually Abdullah, so he would rather know. I don't think they communicated with a trauma surgeon directly, because there is a life-saving system. They put him in the life-saving system, and then our ED people accepted him. Regarding balloon tamponade, it is now well-established procedure, especially for the neck area, and many published paper came from my previous center. Professor Napsaria, he did many research. In fact, the publication Dr. Abdullah mentioned earlier, Sobnak, he was my registrar, and the publication came 50 cases from on over 10 years. I was at that time in that hospital. So out of 50 cases, maybe 4 or 5 cases by me, it was done. So balloon tamponade, I would say, is a now established procedure to do the control, bleeding control. Especially if you have with a knife. Normally, small, as I told, a small maybe nick to the artery or vein. It does compresses if you know how to do it. Even you can use multiple balloons, 2 balloons. And I have done, even in Shinesi King South Hospital, we have done a few cases, not proximal subclavian artery, but jugular veins and injury to the neck. So it is, I think it's a nice way to do the hemorrhage control, especially in that area. This is one thing. The angio, as patient is stable, although he has heart sign, but at least bleeding was controlled by the primary surgeon. So now his hemodynamics is, what we call it, stable. It's a good option to have angio, because it, not only that, because patient already 7-8 hours down the line, and we don't know even his brain status, how much he's. So it's nice to have also to know how his brain functioning preoperatively. And if you know the anatomy preoperatively, you can better plan the operation if time allows. In fact, you see, when I tied the artery, I did not even think second time whether I should tie or I do shunting or I do repair or I do something else, because I know his vertebral artery is coming from the arch. So at least his brain is well perfused, and it's a proximal injury. He has so many collaterals. His fingertips SpO2 is around 100 on all fingers. We can say confidently tie the artery and vein, because if we spend too much time there, actually we kill the patient, because in one stage patient become unstable. And he was requiring a lot of inotropes, a lot of blood products, and he was in coagulopathy. So in that sense, I would say it's a good decision. And in King South Medical City, getting a CT scan maybe takes another 15 to 20 minutes additional time. So it did not even cause any problem, because the radiology people also helped us. I was in actually at that time, Abdullah called me immediately, pushed together the patient. So thank you very much. If I don't know, I answered your question or I missed some part, because it was a few questions.
No, that was perfect. That was perfect, and definitely we'll have more room for discussion by everyone at the end. But I think now to carry on with the rest of our questions, maybe our operative exposure and such by Dr. Abdullah, and then we will allow time for further discussion. But thank you, Dr. Sharaf. That was great.
Thank you. Most welcome.
The third question was it better to perform a high thoracotomy or a trapdoor incision instead of the median sternotomy? Again, back to Dimitriadis in his paper in 1999, He stated that clavicular incision starting at the sternoclavicular junction, extending over the medial half of the clavicle and then curving downward over the deltopectoral groove is the standard incision for suspected subclavian vascular injuries. And he also stated that for proximal injuries, further exposure is required, and our preference is the addition of a median sternotomy to the standard clavicular incision. This combination of incisions is used for both left and right subclavian vessel exposures. He further stated that traditionally it has been taught that for right subclavian injuries, a median sternotomy should be added to the clavicular incision, while in the left side injuries, an anterolateral thoracotomy or trapdoor incision is recommended. But as per Dimitriades in his experience, the combination of median sternotomy and clavicular incision provides an excellent exposure for both sides. And he mentioned that a trapdoor incision is associated with excessive bleeding, severe post-operative pain, and respiratory complications. Subnak, also he approached his patient as follows. Patients bleeding actively from the supraclavicular region undergo median sternotomy with supraclavicular extension and proximal control of the subclavian vessels. Patients bleeding from the infraclavicular region undergo supraclavicular exposure for proximal control and proximal control if possible. If he fails with that, he will move to median sternotomy. Patients undergoing surgery following confirmation of an injury on angiography undergo median sternotomy initially if the injury is proximal to the vertebral artery or if it is involving the first part of the subclavian artery. All other injuries are approached through a supraclavicular incision, failing which a median sternotomy is rapidly performed. You can see here, this is in Subnak et al. Paper, the incision used by them, excluding the emergency room thoracotomy in 2 patients. You can see all their incision include sternotomy, whether it is emergency cases or is an elective, meaning by elective post angiography. It's not elective, but it's post angiography. So all including sternotomy, except for some distal injuries, they will start with supraclavicular. Also here, for some distal injuries, they will start with supraclavicular incision, whether it is right or left. The 4th highlighted question is, was it better to perform a distal control by making another distal infraclavicular incision over the axillary artery in the deltopectoral groove? Because our patient, the distal part of the artery was retracted, and we hardly find that and ligated it. So, and we also faced with some bleeding from the distal backflow from the distal injured part that we could manage with some hand pressure and with meticulous dissection until we get it, then we ligate it. So should we went for infraclavicular incision, would it help? As per Subnak paper, distal control is mandatory because of the extensive collateral circulation in the neck and shoulder region, and is usually achieved with an infraclavicular incision in the deltopectoral groove. The supra and infraclavicular incisions can be joined over the clavicle, which can be divided when necessary. This is an illustration of the separated supraclavicular and infraclavicular wound. Some will join both through the clavicle and divide the clavicle. The fifth question, was it better to manage him using an endovascular technique? I found this paper. It's the largest comparison of outcome between endovascular repair and open repair of axillo-subclavian arterial injury. It was published by Branco in 2016. It includes initially 153 patients, but the matched patient was only 18 in the endovascular repair and 54 patients in the open repair. One downside of this study that it includes both the blunt and penetrating patients. Not like our previous review paper, it was purely for penetrating injury. Some patients were blunt trauma patients. Here you can see in the endovascular repair group, 61.1% were penetrating injury in the endovascular repair and 46.2% in the open repair patient were due to penetrating injury. The average systolic blood pressure in the endovascular repair patient was 115, and the open repair patient, it was around that 104. Um, 50% of the patients were injured in the subclavian artery, and the other 50% in the axillary artery. So 37.5% in the left subclavian artery, 12.5% in the right subclavian artery. So 50 subclavian and 50 in the axillary artery. The most common type of injury encountered was transection and occlusion. Transection in 56.9%, occlusion in 27.8%. So in around 85%, the injury was transection, complete transection, or occlusion of the vessel, which is like grade 4 injury. The other 15% were fistula or pseudoaneurysm. As per Branco, the mortality in open repair was 27.8%, while in the endovascular repair it was 5.6%. The odds ratio, you can see it's just 0.7. So Branco et al. Stated that endovascular therapy has emerged as a safe and efficacious method of dealing with these injuries, eliminating the need for surgical dissection in a bleeding field and therefore decreasing the risk for injury to important surrounding structures. The success rate with this evolving technique has exceeded 95%, with only few failures due to stent deployment failure or inability to cover the lesion, necessitating conversion to open surgery. So the last question is, was it better to attempt vessel grafting instead of ligation? Back to Dimitriades' paper, where the artery was injured in 59 patients of the total 79 cases. Dimitriades attempt reconstructions in all of his patients, 59 patients, primary repair in 19 patients, graft in 22 patients, and autologous vein in 18 patients. Another older paper by Dimitriades, also in 1987 in South Africa. Repair was performed in 94% of those with arterial injury. For SUPNAC, repair of the artery was attempted. He has 50 patients, as we mentioned. Repair was attempted in 46 patients using graft or Savinus vein graft or primary repair or primary resection and anastomosis. Only ligation was done in three patients, which is 6%, and one patient has endovascular stent. The limb salvage rate for SUPNAC was 100%, and there were no deaths. SUPNAC also stated in his paper those sentences. Ligation was performed on 10 of 65 subclavian artery injuries without loss of limb in Vietnam experience. And he mentioned that the extensive network of collaterals around the shoulder girdle generally allows for distal pulses and limb survival after ligation of the subclavian artery. And he said also, although ligation of the subclavian artery may be an acceptable alternative in unstable patients, arterial reconstruction should be attempted whenever possible. Anatomically, extensive collateral flow through the thyrocervical trunk permits the safe ligation of the subclavian artery. Ligating multiple arterial branches may provide additional length during primary repair, but considerable mobilization should be performed cautiously, as these branches provide an extensive collateral network to the upper extremity. So in other words, gunshot wounds generally cause significant blast injury, and usually surgeon should be more alert that ligating those patients with gunshot and destructive injury may cause limb loss. So we have some restriction in our presentation tonight. We didn't comment on the most important and common post-operative morbidity, which is the brachial plexus injuries. And alhamdulillah, it didn't happen in our case. We didn't also comment on the consequences of the clavicular disarticulation or division. We actually divided the clavicle of our patient for better exposure. And it is the most second common related post-operative morbidity in those patients. Also, we didn't comment on the ligation of the subclavian vein. Sometimes surgeons faced with the area that should surgeons should ligate the vein to get more area to try to find the artery and control the bleeding. Thank you.
Thank you very much, Dr. Abdullah. This is a great presentation and a very precious life saved thanks to Allah subhanahu wa ta'ala, the dedication and work of trauma surgeons. This is why we love being in trauma surgery, for saving lives such as these. I would like to open the floor for questions, but before that, I want to hear from Dr. Sharaf, the consultant managing the case, if he had any comments, and specifically to tell us if he, now looking back, would have done anything differently, or would have liked to do another option in repair, maybe endovascular, maybe reconstruction, and hopefully to comment on us about, was he worried about any compartment, any issues with ligating both the vein and the artery in this case, and any other comments really from him would be very appreciated. Dr. Sharaf?
Thank you, Dr. Ahmed and Dr. Abdullah. Yes, just few quick comment regarding the operative technique, whether I should do sternotomy or trapdoor. Even I shared a article in the trauma club group. Even if you look at my article, I also wrote, if it is on the right side, normally we go sternotomy plus minus clavicular extension. If it is on the left side, because it's a little bit superior, the subclavian vessels. So we go normally clavicular incision, sometimes clavicular division, if needed, maybe infraclavicular, additional infraclavicular incision, and plus minus trapdoor to get the control. That is actually more theoretical. Why I'm saying, like I managed few subclavian artery in Cape Town. So stable case, like last night came, had Foley catheter, balloon tamponade, we did angio, patient is stable in the ICU. Then we routinely took the patient to OR. I managed with the supraclavicular incision, and one case, even supraclavicular extension like this. And those cases were actually third part of the, like a little bit distal subclavian artery, because I knew even beforehand what I'm going to do. So it was not very drastic, big operation. Although if you look at the anatomy of that area, it looks very beautiful. Even, you know, VIT, CD, these, that, all the branches in the photo looks very nice, but real life is not that. Real life, this area just bleeds. This is my experience. So I would say, although it is written in the book, especially for the left side, you can say no problem in the exam or if somebody asks. But in real life, from my experience, I would say don't do trapdoor. You will fall in a big trap. Okay, so better in this case, in the particular case, if you, like I did a sternotomy, because when I exposed a supraclavicular incision, one clamp was removed and immediately it was bleeding like hell, and it was bleeding into chest. So, and I am actually, we were ready beforehand. The instrument were ready because it was my plan to go if needed. So it took only 3 to 5 minutes to open the chest through the sternotomy, and Abdullah immediately put pressure from inside the chest into the subclavian vessels, and we took the control. So this is regarding operative technique. And then endovascular technique. In fact, you know, our vascular surgeon are running around to do endovascular technique for this case. But look, if you look at particularly this case, you need balloon coming from the bottom, maybe from another side, to have the control at the just above the arch. You have to bring another balloon maybe from the lateral side. Then you do the distal control, proximal. Then how will you remove? Think about this case, all the 5 bulldogs, and you don't know even where the arterial end, because it was tethered. It was not a single small pseudoaneurysm. So how will you pass the stand? How will you pass the what you call it, catheter, to have the control? I don't think it is a feasible option, particularly in this case. In the literature, they mentioned, you know, as I said, a stable case, small pseudoaneurysm, confirmed by the CT angio, then you do. In fact, we did one case actually previously by our vascular team. He was completely stable, a small stab into the neck, zone 1, and then they did stent. Again, stent, you know, a young fit guy, you have to use many antiplatelet drug and all these things for lifelong. And a small vessel like a subclavian, it is a high chance of even getting blocked again. So, okay, endovascular is a technique, is gaining popularity, but not for every single case, especially unstable case, particularly this case. I don't think is a huge option or a good option. Thank you very much. Any question? Then I will answer accordingly from the audience or from my...
Thank you, Dr. Sharaf. We have some raised hands. Maybe I'll start with Dr. MB. I will unmute you since you're raising your hands.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله.
أنا محمد بوزير.
أهلا دكتور محمد.
Welcome. السلام عليكم.
Welcome.
عليكم السلام.
المدير القديم وحياك الله.
الله يحييكم جميعا. Thank you very much. I am very happy to see the activities coming back again after a pause during the summer. Thanks, Dr. Ahmed, for giving me the opportunity to comment. First, I would like to congratulate the KCMC team about this great case. Certainly, subclavian artery injuries is one of the most difficult injuries to deal with in terms of management, approach, and the dilemma whether to ligate or repair. Thank you for sharing your experience with us. I just had I wanted to ask the team whether did you guys think about doing a preemptive fasciotomy, or was it indicated? Did you think about the risk of compartment syndrome? Yeah, that's it.
Yes, thank you very much. Yes, it is a good question, especially, you know, for the lower limb, if it's unstable patient, I start even with fasciotomy. In this case, upper limb, normally they tolerate, you know, and fasciotomy has its own complication. It was in my mind, and we did a damage control type of surgery. Even we had a plan, if he comes back, no problem, we'll do it. Or even, you know, even the repair of the artery, if needed, we had a plan to even bypass, do major surgery, but alhamdulillah, he did very well. And he, you know, had a perfusion to the limbs, so we did not proceed. Fasciotomy, without fasciotomy, in this case, we succeeded. It is an option, especially for the lower limbs. Yes, you should start with the fasciotomy, but upper limb, sometimes they do tolerate. So you can consider, it's if somebody does it, it's not a wrong. Absolutely correct. Thank you.
Dr. Hassan Mashbari has a question.
Thank you, Dr. Ahmed. Dr. Sharafuddin, it was great to hear from you, and thank you, Abdullah, for the great presentation.
Nice to hear.
Yeah, I'm finally back, and I actually have some of my residents from Prince Mohammed bin Nasser. They're going to be joining us on a monthly basis, so I would like you guys to welcome them. But the question for Dr. Sharafuddin, can you really please give us the really details in the intraoperative findings? Like when you extended the incision, like did you started with the distal clamp, and like how did you exactly approach it? And
No.
what exactly?
Okay, let me tell you.
Like the exact detail. Yeah, I want to hear the exact detail, because those are the crunch. And also the number two is that you already know it's a very, very, very proximal injury. So, I mean, did you just like, I understand you already talked about the sternotomy, but do you think even in left side, if it really proximal, do you think it's, since you have a stable patient, should have not like did a distal, clamp and just immediately did a sternotomy, or you would always approach it regardless how proximal it is with a supraclavicular in a stable patient? So that's, I was really want to hear your opinion, learn from your thought process and the exact distance of the injury. Thank you very much.
Yeah. Okay, thank you so much. So it was our preparation, even the consent was taken, sternotomy and extension of the neck extension in supraclavicular extension. But why I started supraclavicular? I started with supraclavicular incision. In fact, the previous incision by the previous surgeon, we just extended a bit up to the sternoclavicular joint. Why? Because we know in the left side, it may be possible with supraclavicular incision with clavicular division. We did, even the literature also said that. But when we exposed, actually, we couldn't get the control. Means one clamp we removed is bleeding, and then multiple clamps is there, multiple structure is caught, hematoma. So the vascular is very clear. You don't expose hematoma until you get the proximal control. So distal control was not an issue. Issue was the proximal control. In fact, as I told you, our vascular team, they are not experienced with even sternotomy or even thoracotomy. So they were looking at 5, 6 o'clock in the morning, looking for a consultant interventional radiologist to give them a hand, like us a hand with a balloon proximally. Then we remove the clamp, but he was not available. So I did not hesitate. You just straight away, because if you do the sternotomy, you have a full control of the mediastinal vessel from the arch, even heart. Whole chest is in your hand. So that's why in this case, I straight away did the sternotomy. And then if you say operative technique procedure, especially, you have to look at the phrenic nerves, you have to, he already described in the anatomy. So but another term I always use, we call it piecemeal division of the muscles, especially with the scissor, to avoid injury to the brachial plexus. Because if you just cut, you may cut the fiber of the brachial plexus just below the scaly anterior muscle, you know, then artery and the nerve. And very many fibers comes to that area. And especially, you know, as I told you, the photo and the real life is not the same. Although it's a very nice, beautiful photo. So you have to very careful dissection in this area. We did things. I had some experience also that helped actually. Thank you so much.
We have Dr. Mohammed Al-Sanani. حياك الله دكتور محمد, يعطيك العافية. Go ahead.
الله يحييك ويسلمك. Thank you so much, Dr. Ahmed Al-Braikan, for moderating this session and to resume this nice activity. And I thank also Dr. Abdullah Firdaus, very structured presentation, and Dr. Sharafuddin to share this case with us. And I would like to comment again for the exploration for trauma or subclavian injury. We cannot retract what is present in the literature, which is, as Dr. Sharafuddin said, it is most of theoretical thing. Maybe it works with the cadaver or with elective surgery, that trapdoor description. And also they, if you check more, you can see other ways of exploration, like doing anterior thoracotomy in the third space or fourth space or fifth space. This might invite for trouble, and it looks like it is not practical. Even when we mention to this to war surgeons or people who got used to do those explorations, they smile. Anyway, they will keep writing about those things because this is the nature of this pathology. It is rare, and it will keep being rare. And it is lethal with high mortality, and there is a lot of challenges around it. This is for number one. So we cannot take the opinion of other people how to approach this case, but we can mention the preference or maybe a safer approach to do it. Also, I would like to ask Dr. Abdullah if the hand was not perfused. I heard that there was good perfusion in the pulse oximeter despite the subclavian was ligated and patient was in shock state. So if the hand was not perfused, what does he suggest us to do if the hand was not perfused? So threatened limb, we have a threatened limb, patient is unstable and he's doing damage control. What is his thought process? And last thing, if there is a take-home, if I select a take-home message I learned from this case, I think we should never leave vascular surgery team alone in OR, in acute vascular trauma in torso or in neck, especially in the chest. The chest is a black box for them. Chest, subclavian, artery in the neck. Okay, they can enjoy some brachial or femoral artery, but in this area, I think it will add for the patient, and we should maximize the chance of survival in these lethal injuries. So even if the policy is in favor of us and we can wash hand, I think we have the responsibility to work with the vascular surgeon. Especially we deal with more hematoma. They usually deal with elective procedures. So I think it is our responsibility to join them, to have a combined case if they are available, and not to leave them alone like defensive medicine. Thank you so much.
Thank you, Dr. Mohammed. I will answer your second question first. The vascular surgeon and their experience with the chest injuries. In literature also, they suggest if the trauma surgeons, they need colleagues who have experience in managing such proximal injuries in the chest or in the mediastinum area. We have to call the a thoracic surgeon instead of a vascular surgeon. They are more experienced in those types of injuries, although they are not available in many hospitals, thoracic surgeons, especially in peripheral hospitals or in medium-sized hospital. Regarding the first question, if I have no choice but to validate the vessel to save the patient's life, and I was worried about his limb status, I will go with the fasciotomy of the upper limb and reassess his limb post-operative. Thank you.
Yeah, thank you so much, Dr. Abdullah. Just I want to add, if alternative option, obviously, if I did not know what is going on, or if I did not have the CT, I would do the fasciotomy and shunting of the vessels, and I would tie the vein. That was the option to do it. And regarding the mediastinal thoracic surgeon, I don't think in Saudi Arabia thoracic surgeon has the experience with the mediastinal vessel. They will walk away. So rather cardiac surgeon maybe can help a bit with trauma surgeon, obviously. Vascular surgeon, I don't know everybody's capability, but vascular surgeon should be able to manage any artery distal to the arch of the aorta. Should be, it is their privilege. And then other thing is regarding tying, if you look at our descending thoracic aortic injury, like a dissection and all this, most of our cases were managed by the IR and vascular surgeon endovascularly, and they covered the subclavian. So especially proximal subclavian, it tolerates well because of good collaterals. The more you go distally, you must repair the artery. That means the third part. I'm talking about a little bit distal, a more distal, and obviously axillary, you have to repair. So the thing is, shunting and fasciotomy, of course, in a damage control situation, is a feasible option, or it should be done. Thank you.
We have Dr. Abdulaziz Shaher. يعطيك العافية دكتور عبد العزيز, حياك الله, تفضل.
Thank you, Dr. Ahmed. Can you hear me?
Yes, we can.
I want to thank you, Dr. Ahmed, for giving me the opportunity. Just a small question. After I congratulate Dr. Sharaf and Dr. Abdullah Al-Firdaus and King Saud for such a great case, what would have been the approach if the patient were more hypotensive and into a peri-arrest status? What would have been the management in such a case? Let's say it's a fresh trauma and it came directly to the hospital.
You want me to answer or Abdullah first try?
Anyone is fine. It's just I just wondering.
Okay, so Abdullah, let me answer quickly. Thank you, Dr. Shahid. Yes, of course. If he's crashing in the what do you call it, in ER, you go for high left thoracotomy and try to control from the inside, at least some pressure, some sort of technique, and then you take him to wash. So that's a high thoracotomy, and then you extend, as you said, you can go for trapdoor, this, that, to get the control of the full vessels. But you do thoracotomy, high thoracotomy in the ER. Thank you.
We have Dr. Thamer Nooh. يعطيك العافية دكتور. تفضل.
Thank you, everybody. Very nice case, so very impressive save. A couple of comments that I wanted to make, but most of them were covered. But I agree with Dr. Muhammad. These are very rare cases, and it's very difficult to state that there is a standard of care or a standard incision that needs to be followed. I think most of us, maybe face these cases, once or twice or three times in their career, and so I think whatever you judge in the in the operating room that you need to do, you end up doing. The other comment that I wanted to make is if you're unlucky that the blood supply to the upper limb is interrupted or there's ischemia, then obviously depending on the patient's condition, if they're unstable, you shunt, and if they're stable, you might go for definitive surgery or definitive bypass. But that's depending on the available expertise. Thank you very much for this very nice case.
Thank you, Dr. Khaled. Nice to hear from you. Yes, of course. Life first, then you go for limb. This is basic principle. Thank you.
It looks like maybe Dr. Mohammed Sinani still has a comment. تفضل Dr. Mohammed.
Thank you so much. Sorry to comment again, but I have an important question. I take this chance to ask all the panelists in this academic activity. Now, you can see here, it was obvious. There was no notification before arrival of this case. And notification will help a lot. Patient will take maybe 2 hours, 3 hours to arrive. During this time, we can activate the team, even AR, we can activate blood, prepare ICU, we can do a lot of things. And just wondering, I will not discuss whether it is required or not. Was it indicated or not? Does it help or not? Because we know the answer. But my question is, how can we develop the system, trauma transfer, within our cluster or within, the transfer, the life-saving in the digital city is managed by the ministry. What is the way to approach them to improve trauma transfer within the cluster and outside the cluster, to convince people and to improve the RCC Resource Command Center to develop it more? Because it looks like we are slow in this matter. We need a plan, and probably Dr. Thamer Nouh also, he has more experience with them. So what do you think? What should we do to make at least the notification itself? Patient just parachuted in ER suddenly. They said he's life-saving from a flag. This is what I understood from Dr. Abdullah. So what do you think? How do we approach them? How can we make a plan to improve this transfer system?
والله يعني you asked a very challenging question وجيت على الجرح زي ما يقولون. To be honest, the Ministry of Health has a very good system for life saving, and it's there because there isn't an alternative. And so, given the fact that a lot of patients take a long time to be transferred to appropriate care, the ministry has developed this life-saving system. The only way I can see this is that if you develop another system within the cluster, and then we can all go and discuss with the ministry that at least within the cluster, we should follow the cluster transfer system rather than the ministry transfer system. And until that happens at a regional level, like for example, all the clusters in Riyadh, something is better than nothing. You don't want to have a patient that is stuck in a hospital with no hospitals, with no tertiary care facility accepting them. So the only way to go from the current system to your dream system is to develop a cluster-wide transfer system within the cluster, and then negotiating with the ministry a transition. And that will happen. It will take time, but it will happen eventually.
Thank you, Dr. Thamer, for this comment. طبعا it's very difficult to follow a comment بعد Dr. Thamer because he's such an experienced guy and the organizer of trauma care in our country. لكن I just wanted to add something to just echo Dr. Mohammed Sinani. I raised this in the first part of the lecture because I really think you know, I mean, the work here that was done is amazing by everybody. Was there room for improvement in the transfer and the initial assessment? Definitely. There is always room for a better way to do things. لكن and I think if you look at the glass half full and you be the devil's advocate for these smaller hospitals, to be fair to them, we haven't been communicating with them that much. I think, you know, now we have an opportunity because it's becoming more clear which hospitals are referring to our big centers. And it would be really nice if we take the initiative as trauma surgeons and get to know the peripheral surgeons who are there, maybe through some meetings like these or other meetings, to kind of share the knowledge and share the education and sort of be available for them when they face such cases. I'm sure that the peripheral surgeon, if he had a proper and a viable way to communicate with the trauma surgeon on call, he would have done it. I mean, it was clear that the guy was struggling and trying his best to save his life. And I'm sure that if he knew that Dr. Sharafuddin is the trauma surgeon on call at the big center just waiting for the case, I'm sure he would have called him. I mean, this is, it's very difficult to think otherwise. And I think if we make ourselves more knowledgeable and more known to our colleagues in the peripheral hospital, sort of what to do when a difficult trauma case comes, and how to show that we are available, and what to do and what not to do for such cases. And this is an elaboration process. It's not going to happen overnight. But I think I can use a case such as this as a golden opportunity. I'm sure that, I'm sure if the peripheral surgeon had known whom to contact, and that was easy to do, he would have contacted the trauma on call and he would have said that, I have this disaster case. I'm trying to get control of the bleeding. What do you suggest? Should I come with the patient, or what should I do? How much? What should I? I mean, he acted, in the best way he know, and I think he's done a remarkable job. But yes, maybe if he had a hotline to talk to, maybe he would have gotten a Foley catheter in, and he would have communicated back to the surgeon if that had stopped the bleeding or not, and what else to do. Is the chest tube needed or not? Should I intubate? Should I not intubate? How much blood should I send with the patient? Should I come? I mean, I don't want to take long, but I think there is room, but we have to also take some initiative in this, especially in the centers where we know which peripheral hospitals are being attached to us. I don't know if other experts here would have something else to say. We are all ears, but I think this has been a very eye-opening case, and I congratulate KSUMC, Dr. Sharaf, Dr. Abdullah, and everyone who has been involved, even in the peripheral hospital. A life was saved because of hard work. And yes, even that being said, things maybe could have done better, and it's up to us to keep improving. Any one of our esteemed attendees have anything to say or anything to add? Dr. Sharaf, maybe you have a final word to say before we conclude.
Thank you very much. Thank you for everything, and thank you that you give us opportunity to present this case at this level. So thank you for everything. Thank you. So I have nothing to say. If Dr. Thamer wants to make some concluding comments.
Dr. Thamer is always popular. Do you have anything to say, Dr. Thamer? I think your experience.
No, again, I just would like to thank the team at KSMC for their hard work and they keep showing us that they're one of the most important trauma centers in Riyadh and in Saudi Arabia, and we're very happy to be privileged to learn from their experience. Thank you very much.
Okay, it's been a really entertaining and knowledgeable hour and a half. I think this is an excellent start to our academic year, going to a monthly meeting. We encourage participation from all doctors, all nurses, anyone who's interested in trauma. Everybody is welcome, residents, consultants, registrars. This has been a great activity so far. I hope we can take it even further. Our next meeting will be, inshallah, the beginning of next month. We're looking forward to see you all there, inshallah. Further details will follow. Thank you, everyone. Thank you for the presenters, for the listeners, everyone who had a question, who had a comment. This has been great. With this, we conclude our monthly meeting. Thank you very much.
Thank you, everybody.
¿Tengo yo?
before I start treatment of CLL. If somebody is already being treated, if they're on venetoclax rituximab combination, then I wait until they're done. If they're on on acalabrutinib, then I recommend that they get vaccinated while they are on acalabrutinib. I think some protection is better than no protection. And now we also have boosters, which have been approved for immune-compromised patients. So I recommend this now for patients on current acalabrutinib therapy.
Thank you. So this question for all, considering a toxicity profile, how now concept of toxicity profile, how much its impact on the decision making for choosing the front line treatment. There was one question about patients, as you know, that CLL patients, elderly patients, and many of them, they have cardiovascular diseases. So in a patients with, for example, who needs dual antiplatelets, what would be your recommendation in choosing front line? So maybe Dr. Abdul Karim or Prof. Arashi.
Yes, okay, yeah. Actually, that's the benefit of having multiple different effective treatments. So you could choose which medication suitable for your patient. So like for patient with maybe pre-existing atrial fibrillation or uncontrolled atrial fibrillation or need anticoagulation, we see most of these trials like excluded patient on warfarin with BTK inhibitor. So in that patient, maybe I would go with venetoclax-based treatment. So it's depend, like if you have more treatment available, you would use them in suitable cases.
Prof. Marashi, any input for Dr. Alex?
No, I think that what treatment you choose depend upon the profile of the patient as well. What are the, like in this patient, we didn't want very aggressive which might produce tumor lysis because he has renal impairment. So we wanted something which is going to give a smooth sort of control. He had hypertension, not something that will worsen the hypertension. So a number of factors come into play when you are deciding. I have another patient, for example, he's a pilot. He wants limited time therapy because, you know, if he's on any type of therapy, maybe they will not allow him to fly. So we chose something like, which is time limited, venetoclax obinutuzumab. So at least, you know, now, so it just happened that it was during the time when the flights were reduced. So at least he didn't lose too much of work. So I think what you decide depends not only on the disease, genetic risk factors, but also on the patient factors, the drug profile. So I think this is how one would choose this therapy.
Dr. Alex, sometimes we used to consider ibrutinib as one antiplatelet. So if patient is on 2 antiplatelets, we give him 1 antiplatelet and ibrutinib. Is this what you used to do also?
Yeah, so thank you, Professor Said. So it's, you know, it hasn't been well studied. So the retrospective studies have shown ad hoc analysis, retrospective analysis, that use of ibrutinib in combination with antiplatelet agents like aspirin does not seem to increase the risk of grade 3 for high-grade major hemorrhage, basically. Does not seem to increase the risk of major hemorrhage. So I frequently combine BTK inhibitors, in particular, second generation, like acalabrutinib, zanubrutinib, with aspirin. I do worry when patients are on aspirin Plavix, I do worry to add a third antiplatelet agent, which at that point BTK inhibitor becomes. So I start thinking about venetoclax at that point. And sometimes I speak with a cardiologist or vascular surgeon, trying to figure out why they are on these drugs, how long they're going to be on these drugs. And either I wait until they stop, or we come to an agreement that maybe they could be on aspirin and acalabrutinib or ibrutinib alone. Yeah, so I've done that a couple of times too, but there is not much real data for that. So it's on an individual case basis.
Okay, I think we are run out of time, but maybe last question for you, Dr. Alex. For young, fit, new CLL mutated IGHV? Would you go for chemoimmunotherapy or for novel agents?
Novel agents. I barely use chemoimmunotherapy anymore because the efficacy of novel agents is so high. If you talk about BTK inhibitors or if you talk about venetoclax, when you do them up, the efficacy is so high. I really do, and patients usually don't want it when they hear about those options. As long as novel agents are available, I always go for novel agents.
Just for this subgroup where chemoimmunotherapy might have a potential cure.
Yeah, so that's a very good point. And you're talking FCR, right? For fludarabine-based therapy. I usually, if I see a really young patient like 50, yeah, then and they're healthy, I talk to them about FCR, and we check next generation sequencing panel. I have to admit that most of the time I find some mutation which stops me from using FCR. It could be Notch1, SF3B1, TP53. So I usually, every time I've thought about FCR, I found something which would tell me that it's probably not a good choice. But say in a hypothetical world where the patient doesn't have high-risk mutations, no high-risk mutations, and they have mutated IGHV, they're young, I think it still can be used. I think those patients are fewer and far between. And many of them still say that they do not want chemotherapy because of risk of leukemias, risk of prolonged neutropenia and infection.
Thank you. Is Dr. Al-Hareji there?
Yes, Dr. Ahmed.
Sorry. Okay. So Dr. Ahmed, maybe we'll give you the last question. You mentioned during your part of routine workup, you do mutational status and FISH. Just I would like to clarify the point of doing FISH for asymptomatic patient. Would you do it at diagnosis, or would you recommend to do it only at the time of need for treatment regarding FISH?
That's a good question. Sometimes we know that we do it before starting the therapy. This is the time where it will impact your decision on treatment. But sometimes the patient, if he has an early asymptomatic disease based on the recent data that we have, some of the patients, they would ask you like, when do you think that I would start therapy? So in order to answer this question and to have the CLL IPI, we usually do it at diagnosis. But it would not impact your treatment. So even if you have 17P or P53, I have patients who have 17P or P53 and they are asymptomatic. We usually monitor them.
Okay, so by this, I would like to thank attendees for their time. I'd like to thank all our great speakers for their excellent presentations. I'd like to thank the organizers and GSK for sponsoring this meeting, and wish you a good night and hope to see you soon in another meeting. Thank you.
Thank you.
Thank you.
Thanks.
Fine.